So this is another episode of Off the Cuff Nurses, and we're going to talk about correctional medicine today. And I am Dr. Minter, and I've got Dr. McConnell, who's an ER physician and a jail medical director. And we work together, and he is going to continue his story about how he wound up in jail. Long, convoluted story.
Yep, definitely wound up in jail.
Yeah,
a place I never thought I'd find myself.
Well, maybe.
Working, at least.
So anyway, so we left off in part one that you had just, I'm going to recap in case anybody has not seen that episode. So you were in a helicopter crash, and you're now missing your lower right arm, right? Mm-hmm. With a whole lot of various injuries. And you're in Kandahar, which is probably a rudimentary hospital.
Yeah. At that time, it was the in-country. I think Bangor might have been bigger, but it was one of the two in-country hospitals that I'm aware of. But it was still pretty austere. Mm-hmm. They had very limited amounts of what they can do. Typically, they try to get people shipped back to Germany or Kuwait. I think Kuwait was where they would send people if they got significantly injured, and that was where the real stuff would happen. It was essentially stabilization until then.
Right.
And that was where went from Kalat to Kandahar after the crash, and then Kandahar, it was time to go out of country. And, at this point I've been extubated and everything.
How long were you intubated for?
Just a day or so, I think. Again, I don't remember any of that, but I believe it was pretty much just intubation for the flight back to Kandahar. And then they did the extubation. At this point I had told my dad that, I'm hurt and coming home. I was very worried that, I'm not going to be able to go to med school, because again, I'd already been accepted. And I was like, oh man, if they find out about this, they're not going to want me there, because I was worried that the injury would preclude me from going. And foreshadowing here, it does preclude some stuff. So I remember we're getting ready to leave Kandahar, and all the guys from my company or that we're with at this point are coming in, saying their goodbyes and everything. And I did not know, again, I was unaware that anyone thought that I wasn't going to make it, but from what I remember, some of the guys were told, go say your goodbye. You may not ever see him again. Mm-hmm. So to me, I'm like, oh, I'm going home. Yeah,
they're particularly nice to you. Yeah. Like, why is everybody being so nice to me?
Yeah, right? I don't have the world's greatest personality at times.
Not you.
Yeah, it's a flaw I'm well aware of. I try. I mean well, but
yeah.
Between squirrel and ADD and running my mouth too much, it gets me into trouble.
Yeah. So, but they were being nice to you.
But guys were being very nice. They brought me the things that mattered to me at the time, which were my cav hat, because I was a cavalry officer. So I wanted my cav hat. You don't go anywhere without that. And I wanted my laptop computer, and I wanted my pillow, because anyone who knows me knows I got a pillow that goes with me everywhere I go.
Okay.
And it's been through thick and thin since I was young. Still have it now on my bed today.
Okay.
Multiple pillowcases later, but I wanted that. Needed those three things, and I was ready to go.
Well, we're glad you changed the pillowcase.
Yeah. So I remember, we fly back, and I flew through, I believe it was Kuwait, which, interesting side story there. The physician who took care of me there actually ended up being one of the physicians I was in a group with years later in an emergency medicine group. And he knew that he had been a physician at that facility at the time that I came through, but, so many people go through there, he didn't remember me at all. But one of his medics had gone to PA school and came to do a rotation with him as a PA student. And when he saw me, he was like, "You were a helicopter pilot." And I'm like, "Yeah." He goes, "We took care of you."
Wow.
I'm like, "What?" He goes, "Yeah, you came through us in Kuwait." He's like, "We took care of you when you came through." He goes, "You were telling everybody how you were going to be a doctor."
Wow.
And he goes, "I always kind of wondered if you really were and if you really actually made it or not." I was like, "Oh, wow, small world," ended up, this is many years later, working with one of the people who helped take care of me.
Wow.
But, from there, I went to Germany, and then Germany, each place I got, they're like, okay, well, he's stable enough to go to the next place. So I got to Germany, overnighted in Germany, and then flew back to Walter Reed.
Right.
Was there for a day. And at the time, if I remember correctly, if you lived east of the Mississippi, you went to Walter Reed. If you lived west of the Mississippi, they sent you to Brooke Army in San Antonio.
Been there.
And while we lived east of the Mississippi, it's only by like 15 miles or something like that. So they decided to send me down to Brooke Army. And by the time I got to Brooke Army, it had been probably 10 days or something, 8 to 10 days since the crash. Mm-hmm. By this point, I could actually get myself up a little bit and walk, a little. They'd taken the catheters out, stuff like that. And there basically was just all the recovery. At this point, I was dead set that I was going to keep flying, and I wanted to keep my career going in the military, like whatever, the hand, who cares? We'll do something about that. Modern technology, I'm sure we can do something. So I was in the hospital proper for a couple of weeks because, again, there was a lot of other injuries that had to be addressed. And then they moved me out of the hospital into essentially the hotel across the street. It's the military hotel, and because I was an officer, I got to stay there as opposed to the barracks.
Do they have any roaches? Like when I was at Fort Sam Houston for a couple nights, they had big roaches that used to come across.
No, this isn't the one that was next to the old hospital. This was the nicer one they built next to the new hospital.
Okay.
Stayed in both of them at different points in my life, but no, I stayed there and began my fight with the Army to try and stay in.
Uh-huh.
And
you're the only one probably would want to do that.
Actually, a lot of the guys there want to stay in.
Yeah.
Because people feel that they didn't get to finish on their terms, or they want to keep serving,
Uh-huh.
So I wanted to stay in. I kept fighting the Army. I started doing fixed wing classes. That was when I got my fixed wing ratings at the civilian airfield there. There was a bunch of the Air Force, I think they're navigators or something like that, but they get like their basic flight training there. So I was going over there and doing all my training with them.
Uh-huh.
And got my fixed wing ratings for the little Cessna stuff and everything.
Yeah.
And ultimately, the Army kind of wasn't real hot on the idea.
No, really?
If I had been Air Force or Navy, I probably would have been able to stay in and keep flying, probably even helicopters. And if I was willing to fly airplanes, I might have been able to stay in with the Army. Our flight surgeon was well known for keeping guys in that everybody thought for sure their flying career was over. He would find technicalities and loopholes and stuff that as long as they could do the job, they could stay in.
Uh-huh.
And ultimately, he sat me down along with the 2-star general who was kind of backing me. And was like, look, here's the deal. Like, I'm going to be honest. He's like, your days of flying helicopters, 95%, 99% sure those are over.
Uh-huh.
He goes, but if you want to stay in and fly airplanes, we can, he goes, I will guarantee that if we can get the U.S. Army Aviation Research Laboratory to sign off on you, I can almost guarantee we can get you into flying airplanes, which the Army does have a lot of airplanes, but a lot of people don't realize that. And at that point, I was like, med school's looming, they're wanting an answer. At this point, they had found out about the hand, and they were okay with it and everything. And I was like, you know what, I'm just going to go ahead and, long story short, take the retirement and medically retire as a captain and then go to med school. So I got out of the Army last week of February of 2007, bought a house in Johnson City, spent the next several months teaching myself how to work on houses, renovating it because I didn't have enough money to pay anybody to renovate it. Mm-hmm. So, and the house that I bought needed a lot of work. So taught myself how to lay tile, frame walls and stuff like that, built out the inside of the house over, the next several months, and then started, what day was it? I started medical school July 27th. I knew because it was my birthday. I turned 30 on the day I started my med school.
Wow.
Went in initially thinking probably trauma surgery is where I want to go, which, again, that whole personality thing, it fits very well in that community. Mm-hmm. But emergency medicine was another close second of things that I was kind of interested in doing, and kind of geared myself in those directions. And I think it was third year of med school. I'd already started to kind of run into a lot of roadblocks. My biggest fear when I started med school was that patients are going to worry about me, that patients aren't going to want a guy with a hook taking care of them.
Mm-hmm. What about your colleagues or the students? What did like when you walked into med school? Did anybody say anything, or are they just?
I mean, people thought it was interesting and everything, and a lot of people were like, "Oh, I would never be able to do this." And I told a lot of a lot of the people I was in school with, I'm like, no, I'm like, I guarantee you would. I'm like, if you have the personality and drive to get to medical school, you have the personality and drive to get there with one hand. Yeah, I think most people, it would not have stopped them from going. There might be a few, but by and large, there's a few other one-hand ER docs out there, and I mean, they made it with one hand, be it congenital or otherwise.
Not many, though.
No, I'm aware of 4 total, including myself.
That's not very many.
But, yeah, I mean, my class was supportive. The school was supportive by and large. But one of the things I got all the time was, like, oh, you're probably going to want to go into psychiatry or something, huh? And I'm like, no, I don't want to do psychiatry. Nothing against psychiatrists, but not my thing.
Right.
Just like helicopters attract certain personalities, different areas of medicine attract certain personalities.
Right.
Anyone who knows trauma surgeons will tell you they are all kind of similar, and they're not generally well known for having the most charming, lovable personalities,
right.
Much like me.
Yeah. My old medical director in prison, he's deceased now, but he couldn't keep anybody because he used to throw charts.
Yeah.
and they didn't tell me that when I started.
Yeah. I'm not that bad. No, some of that might be I got a lot of leadership skills in the Army, and you learn how to lead.
Well, he was Army too, but
well,
I don't know. I just thought it was part of his charm. But anyway.
I've never been that bad, but I can be very verbally stark.
Uh-huh.
I don't mince words when the time comes to it.
Right. I get that.
I don't think there's many people out there who wonder where they stand.
Right.
Part of my charm.
Yeah. Well, that's why we get along, because I'm the same way.
But I got that same thing a lot of times. Everyone assumed that you're not going to want to do anything technical because of your hand. I was like, no, I still want to do surgery. I want to do this, that, and the other. And I got a whole lot of, you can't do that. You're not going to be able to do that.
Like from who?
From the physicians that I worked with, the people at the med school, not so much from the classmates, but a lot of other doctors I got that from. You're not going to be able to do that. You can't do that, which didn't sit well with my personality of, you're not hearing me. Let me tell you what I'm going to do.
Well, like what, though? What did they say you couldn't do?
Oh, like one example I can remember, when I was interviewing for emergency medicine, I remember I walked in and I sat down across, I'm thinking how to tell this story here. You learn when you're missing a body part or you're visibly disabled. You learn the look you see on people's faces when they've dismissed you.
Oh, okay. Yeah.
You see it, and you see it a lot, and you get used to it, and you know it. And I remember I walked into this interview because in all of my stuff, that when you send all your interview packet in med school, I didn't say anything in there about having one hand.
Well, you shouldn't have to.
I mentioned that I was combat injured and whatnot, but didn't say anything along those lines.
And this is for what, though?
This is for emergency medicine when I was interviewing for residency.
Oh, residency. Okay.
I remember I walk in and this program director is there, and he sits up and goes to shake my hand, and I put out my left hand. He looks at me. He looks at the hook. He shakes kind of half-heartedly the left hand, and when he looks up at me, I can already see the look on his face of, you ain't coming here. And I sit down, and we start talking, and he's like, it's very admirable that you want to do this, but you can't. And I'm like, well, sir, I definitely can. He goes, yeah, no, you're not going to be able to. I appreciate that you have the drive and you think you can, but you won't be able to. And I'm like, well, sir, I can. I'm like, I promise you I can. He goes, no, you're going to find, like, it was like, for example, intubating somebody. He goes, you can't intubate somebody with a hook. You're not going to be able to do it. And I'm like, well, sir, I've already at this point logged, I think, 57 intubations. And he goes, yeah. When you're doing it on a mannequin and the pressure is not on you, that doesn't mean anything. He goes, but when you're doing it on a real person and the chips are down, you're not going to be able to do it. And I'm like, no, sir, those are on real people. He goes, yeah, I know you think you can, but you can't. And I'm like, in my head, I'm like, do you hear me? Are my words reaching your ears? Because I'm sitting here telling you that I've literally done this on 50-something people who were alive and continued to remain alive after I did it.
Wow.
I had another one say something to me very similar about that with central lines, that I won't be able to do central lines, that I won't be able to do suturing, just basically anything technical that involves two hands.
Right.
Because I think most people, especially in emergency medicine, in emergency medicine, you're trained to very rapidly assess somebody, make a decision, and stick with it. And we all, I'm sure myself included, consider ourselves experts at reading people and making accurate decisions right away. And we can definitely get ourselves into trouble by sticking with those decisions when they've been proven to be wrong. It's called anchoring bias.
Okay.
You know, and that's why you see in my emails, I tell you, don't anchor on your diagnosis. If what you think is going on with your patient isn't matching what you're seeing in the labs or the physical exam, take a step back, because that's not what's going on. You've anchored and you're wrong.
Right.
You know, and that's what I was running into with these program directors. You know, they were anchored on that I can't do it, because they'd look at me, they'd think to themselves, if you cut off my hand right now and sent me down to the ER and told me to intubate that guy, could I do it? And if I couldn't do it, no way could this guy who's never done it be able to do it. So I think that's probably what kind of killed me on a lot of those. My charming personality probably didn't help either. I've been told that I interview well for those kinds of things, but I'm sure, you know, when you see that look of dismissal come out, I'm sure it kind of raises the hackles a little, you know, and there might be people who think I have a chip on my shoulder or something. And one of the things that people forget, I felt people forgot about me, is that when I was interviewing as a med student, I mean, I looked like I was 12 years old still.
Oh, yeah.
I mean, I always looked relatively young, not anymore. But when I was young, I looked younger. And I think that people forgot that I brought 12 years of military experience to the table before I ever set foot in the medical arena.
Right.
So I wasn't your typical student.
Right.
But I remember one of the physicians when I was a med student, we were doing a simulation for a lab, and he leans over and he's like, well, think of how it's going to feel the first time you see somebody, one of your patients, die. And that's really going to stick with you.
Why?
And I was like, yeah, it's a lot like the first time you watch somebody die in combat. That sticks with you too. And he just kind of like, you know.
Because he thought you were younger.
He was, giving me this like bit of wisdom of life of like, you know, open your eyes. And like, yeah, no, I've seen this. It sucks. You know, I've watched people die. It's not a great thing.
So you finally found a position, or? Well,
I interviewed far and wide. I interviewed more than anybody else in my class. I was not top of my class in med school. I was not bottom of my class in med school. I was in the upper half.
Well, at least you weren't at the bottom again.
No, not at the bottom, thankfully. And I mean, even the person who's at the bottom of their class in med school, as the joke goes, they still call them doctor, and they're still phenomenally trained.
Right.
It takes a lot to get there. But I interviewed far and wide, and ultimately didn't get in to emergency medicine. Had to do what they call a transition year, where I went back through and tried a second time around to get into emergency medicine, and managed to find a program that was willing to take me. Actually, that time it went from nothing to bird in the hand, two in the bush, in that there was a program that I interviewed at my second time around, in which a friend of mine, one of the other one-handed emergency physicians, had also interviewed at and had gotten accepted at. And at the time that I interviewed there, she was now in her second year of residency, because we graduated med school at the same time. So they were been there, done that. They already knew one hand doesn't make a difference. You can still do everything just as fine. And they actually extended me an offer outside of the match, back when that was still something they could do. They're like, hey, if you want to sign the contract right now, we'll sign you to come on with our next class, and you're guaranteed a spot.
Nice.
You know, and I was extremely appreciative that they would do that. But I really wanted to try to make it down here to Tampa. And so I told them, like, look, I'm deeply appreciative. I understand that at the time I had a lot of friends and stuff that were in this area. I was trying to get to this area. I'm like, I would like to make it to this program. I'm like, so I hate to say no. I'm like, because again, it's a bird in the hand, two in the bush kind of thing. I'm like, but I'm going to decline. They're like, you know what? They're like, we totally understand. They're like, understand that we're going to put you as our number one rank. They're like, so if you don't get into where you're going, if you rank us high enough, you're coming here. So again, really appreciated those guys for that. But ended up getting my top choice. So I went from not matching anywhere my first year to getting my number one pick the next year, which, a lot of guys worry, or guys and gals worry that, if I didn't match somewhere, will I ever be able to again? Oh, no, you might get your top choice the next time around. So I ended up coming down to Tampa, where they had seen me as a med student rotate. So they already knew that I could do what needed to be done with the hook, and were willing to put up with my personality here to do it.
Good.
And trained me here. So I did my 3 years of training at Tampa General, which is a level 1 trauma center here. And then I moved over to the level 2 trauma center here in Tampa and was there at that group for 5 years, seeing all the gunshot wounds and knives and stabbings and anything you can think of. Very procedure heavy field. Again, lots of stuff to do. Always had a really good time doing it. And then COVID rolled around, and because so many people got laid off, I was one of the junior people at that group. So I ended up getting laid off from there and had to scramble to find a job. And you would think that you would never run into an issue finding a job in emergency medicine, but the same issue that I ran into trying to get into residency, I also ran into in trying to get hired in jobs. Mm-hmm. You know, I joke, every single job I ever interviewed at via a telephone or video interview where they couldn't see the hand, I had a job offer. Every single one I ever interviewed at in person, I did not.
Wow.
Only one thing changed. I mean, is my personality that different on video? Perhaps. Uh-huh. You know, you know, I remember one of the jobs that I took, they offered me a job. I took the job. I got licensed in there and everything. I went and I showed up for my very first shift for orientation, and the medical director came out to meet me. And when he looked up after trying to shake my hand, I saw that look. Yeah. And I was like, oh man, guess I'm not going to come here again. And amazingly, they never had any availability on their schedule ever again after that first orientation shift. Wow. They couldn't even get me to more orientation shifts, just no availability. You know, and after a year of no availability, I just finally resigned. You know, I'm like, okay, I guess obviously y'all don't want me here.
Right.
And at that point, COVID was fully raging, and I ended up getting hired in as what they call a locums doc, basically a hired gun. Mm-hmm. to go out and help with these vaccination efforts and COVID clinics and stuff like that. So I got hired to go to this facility out in California, which at the time was a facility that there wasn't really much going on at. It was only a 2-week contract, but put some money in the bank and whatnot. And as I was getting ready to leave, I said, hey, do you all have anything else out here? And like, because if I fly home, I'm not going to turn around and fly right back. And they're like, actually, we have a job that just popped open. They're like, it's at one of the largest COVID vaccination sites. They're like, you're not really going to be seeing patients as much. They're like, it's for a medical director. But they're like, you're going to be working with a variety of different government agencies and everything. Are you interested in that? And I'm like, sure, yeah, send me. That sounds good to me. How much you paying me? Yeah, I'll go. So they send me over there, and I spent. Initially, it was just a 2-week contract, and by the end of that 2 weeks, they were eager to have me back and bring me on. For the duration. So they ended up bringing me on as the medical director for the entire time that the site was open, working with CAL FIRE, CAL OES, which is Operation Emergency Services or something like that. FEMA was there, the National Guard was there, Active Duty Army was there, and we were seeing something like 5,000 people a day come through there. And it was interesting in that I was one of the only people there who spoke everybody's language. You know, at one point when I was a medic, I had gone through paramedic training in the Army, so I kind of knew that. Obviously, have the medical experience as a physician, but also had been in the Army, so knew all the Army lingo, so knew kind of how to handle everybody. And I remember somebody asking me once, like, did they bring you because you know everything on all these different entities? And I'm like, no, I think it's just fortuitous that I ended up here.
Right.
But I ended up doing that job for quite a while and kind of made a name for myself to where when that site shut down, the California Department of Public Health kept asking for me to come back to run these different facilities in different areas around the state until all the efforts finally started to wind down. Mm-hmm. At which point in time I came back, and I had been in this entire time interviewing for trying to find emergency medicine jobs, but still not getting any traction anywhere. And then finally got hired into another emergency medicine job at a small, what we call a tertiary care, kind of a hospital that doesn't have much in the way of facilities there. Right. So doing a lot of transferring and stuff like that. Worked there for about a year, and one of the other physicians I worked with there, Dr. DePalma, he had just taken over with the same company I'm with now as the medical director at one of the local jails. And he's like, man, it's great. It's perfect for emergency medicine. And I'm like, really? Are you sure about that? He goes, dude, I'm telling you, you should think about this if there's ever an opportunity. And then a few weeks later, he's like, hey, I heard that this local jail over here is looking for a medical director. If you're interested, and like, put your name in. I'm like, yeah, sure. So they put my name in and brought me out to interview, and apparently they had been interviewing multiple medical directors and hadn't had any real success. And they interviewed me, and I thought, well, it seemed to me like it went well. And then, they came back and offered me the job, and we negotiated on it. And ultimately, I took the job where now I get to be in charge of you.
Yeah, that's right.
And I remember
Anthony's over there laughing.
I remember after I'd been there a couple of months, I sat down with the colonel of the jail, and he told me, he's like, when you interviewed here, he goes, I was so glad to interview you. He goes, because you were the first person I'd met that had the particular set of skills that I've been looking for this job. And I was like, wow, I've never had anyone call me an asshole so nice to my face. But I mean, I understood what he meant. He's like, we're looking for somebody who, iron glove, or iron fist in a velvet glove. Somebody who can make things happen, but realizes it doesn't have to be brute force at all times, but is willing to put up with the different personalities that we're going to have with the, I'll say, unique things that happen with our particular site, because as Mentor knows, our site's a little different than a lot of others.
Yeah, and jail is different. So what's the biggest difference between working in jail, not one particular jail, versus ER?
You're much safer in jail.
Yes,
Much
that's
safer.
true.
I would get physically assaulted about every 2 to 3 months in the ER. Sometimes it's a demented little old lady who slaps the fire out of your face because she's demented and doesn't know what's going on. Sometimes it's just a not nice person, not a nice person. Somebody who wanted drugs and you're not giving it to them, or somebody who just has a personality disorder. It's interesting. One of the patients that I've seen at jail, I have also taken care of at multiple other hospitals in Tampa, as well as had seen him in the week before I came to the jail at my last job, at a jail. I had seen him at my last job, which was quite a distance from the jail. He wasn't the nearest hospital. And that was his first time ever coming to that particular hospital. I remember the nurses were kind of up in arms about him because of how he presented. And as soon as I saw him, it made me laugh. And I told the nurses, I'm like, hey, I've known this guy for better part of 6 years now, 7 years. I'm like, this is just him. There ain't nothing wrong with him.
Right.
This is just who he is.
Yeah.
And he's actually with us right now, I believe.
Well, that's the difference in jail and prison. So I came from prison in Virginia, and that's, to me, prison is internal medicine. People are stable because they've been in jail for a year, and then most of their issues are somewhat under control, unless they don't want them under control. Jail is more like an ER, because you never know what you're going to get coming through the door.
Yeah, I've told the people that interview with us, and I've tried to recruit other emergency medicine physicians into jail because, as Dr. DePalma said, he's right, it is. It's the perfect job for emergency medicine. Because jail is concerned, just like you said, it's not long-term internal medicine. It's short, what's going on right now. Jails are interested, I hate to say, in saving money, but they're interested in saving money because it's our taxpayer dollars that are paying for what's going on.
Right.
So they don't want people getting workups that aren't necessary. And the big thing they don't want is people who don't need to go to the hospital going to the hospital.
Right.
Because as we all know, inmates can be convincing and persistent in their desire to go to somewhere where it's a nicer bed and nicer food and whatnot. So it helps to have emergency medicine training because you're used to seeing emergencies. You know what does or doesn't need to be seen in a hospital.
Right.
And if you have the labs and EKGs and x-rays and all that stuff available to you at the jail, you can take a look at this guy and go, hey, this guy doesn't need to go to the hospital. He's good here.
Right.
So it worked out very well in that respect. One
of the things that you have that's highly unusual, like I've told you, is ER and jail.
Right. I'm board certified in emergency medicine through the American Board of Emergency Medicine. It's not the typical route that most people go to be as a medical director. A lot of the medical directors for jails are family medicine or internal medicine. Unfortunately, correctional medicine has kind of a bad reputation in the medical world of like, oh, that's where you go when nobody else will hire you. Mm-hmm. And I myself had kind of thought that prior to going there. And the reality is it's where you go if you want to see some interesting medicine.
Right.
Because you will see everything. We had the guy with the pemphigus vulgaris, this very rare disorder, that it ended up being the dentist who made the call and figured out what it was because of how uniquely it presented and how it was just something you never see.
One of the things that I see when I do malpractice cases, and I do a lot of them, is a lot of times that the other side, whatever side it is, usually the plaintiff side, is opining, and it's usually a ER physician saying they should have gone to the ER.
Right.
And I had a plaintiff attorney tell me, we just discount that because every ER physician says they need to go to the ER.
Right.
So, but they don't understand that corrections has this, you just can't, you can send people to the ER, but there's this whole ripple effect. You got to chain them up. It's staffing,
right.
It's et cetera, et cetera.
Yeah. In the cases I've been involved with, that's the thing I see is, it's failure to send people to the emergency department when they clearly needed to go to the emergency department. And, the ones I've seen, there were no doubt, like, this should have gone. The one case where the medical director had a policy of you can't send them to the jail, or you cannot send them to the emergency department until you run it by me first, just blew my mind.
Right. Well, and I've seen the opposite also, is that they say, well, they should have gone to the ER or whatever, and they may not have needed to go to the ER, and there's actually no case. So, and they have appropriately addressed the issue in the jail, or they said, well, this patient should have done this, or they should have done this or that or whatever. But the jail has made the steps to make the diagnosis. There's a lot of deliberate indifference cases that they're trying to prove, saying that the jail didn't do anything, when they have.
Yeah, our jail has the ability to handle basic hospital level patients. And that's one of the things that I tell people when they come. Essentially, you're going to be working at an urgent care / mini hospital. One of the things I've done is, in my position as director, is tried to reach out and talk to some of the hospitalists and the director of the ambulance services and stuff like that, and let them know what we have available on site.
Right.
Because if you have somebody who needs IV antibiotics, that person might have spent a week in a hospital, but we can take care of them just as well at the jail, giving them all the care they need. We've got the pumps, we've got the meds, we have the nurses, we have the physicians on staff to do everything.
Right. And that varies jail to jail.
Right.
Some of these jails, in the middle of the country, I won't say the states that I've reviewed, they don't even have nurses on site. They might have like an LPN on call.
Yeah.
Or they have a physician that comes in 2 hours a month.
Yeah.
So, it's huge variance of care.
Yeah, and to me, I understand the financial aspects of it. To me, overall, but to me that I won't say hurts my heart, but it makes me kind of sad for people in jail. One of the things I say, you hear me say all the time about, I call it the orange jumpsuit syndrome.
Uh-huh.
Where we send people to the ER and they just get kicked straight back to the jail with almost no workup because the ER physician walked in, saw the orange jumpsuit, immediately made the decision that this person is lying to me, and didn't do anything and sent them straight back. Uh-huh. And you see me send people, I'm like, all right, well, I guess we're going to send them to a different emergency department now.
Right.
Where they actually, we had the one guy that they literally wrote in their note that the patient is malingering and refuses to interact with me because he won't look at me because the guy was having a stroke. And they sent him back. And when I go see him, I'm like, this dude is clearly having a stroke. Like, this is day one medicine. I don't know how this physician didn't see this. And we send him to another emergency department where they scan his head and find the big head bleed. Right.
Well, you've got that unique perspective, and certainly the military perspective that, I'm sure that everybody would enjoy, even though you don't think that they would. Okay, so we're going to hold it right here because we're right about a half an hour. So I am Dr. Minter, and I've got Dr. McConnell with me, and this is Off the Cuff Nurses. We will see you next time.